Kenya Medical Practitioners and Dentists Council certified general adult psychiatrist with a subspecialty in child and adolescent mental health. She has almost 15 years of experience in the mental health field in both the private and public sector. She has previously taught at the University of Nairobi's Department of Psychiatry and Behavioral Sciences. She is widely published and has mentored several students and continues to do so. Dr. Judy Kamau is a passionate mental health advocate and thrives to bring peace of mind to families. Karibu sana, Dr. Kamau.
Thank you, Dr. Mariga. Yeah, I'm hoping I'm audible. I think we can start. I'll be talking about schizophrenia in children and adolescents. I think most of us have an idea, especially if you're in a mental health space, you have an idea of what schizophrenia is. At least you have an idea of presentation, but we'll just be mainly focusing or teasing out some of the differences that we may find with children and adolescents. Is it different in terms of management? So I'll be giving a brief background. Then we'll go into risk factors related to schizophrenia in children, and then also look a lot about the differential diagnosis, and then we'll try and simplify management. So it's, yeah, so just a bit of a background. Yeah. One of the most severe psychotic disorders or psychiatric disorders that's known is schizophrenia, even for adults. So if you imagine a child who has schizophrenia, I think it's very fortunate that psychotic disorders are rare in children. Also, we have to bear in mind that we have transient or short-lived psychotic experiences that are common in otherwise healthy children. So children will have imaginary friends. We'll see things, or they also have very vivid imaginations. So we have to be very careful on how we interpret the presenting symptoms that a child would give out or would describe. And also, even for adolescents, sometimes they may not be able to describe their symptoms as well. And especially nowadays, you're finding them very well-read or investigative of psychiatric disorders and symptoms. So by the time they come to your clinic, they're already telling you, I'm hallucinating, I'm very paranoid. So let's take it, we have to really be very careful on how we interpret some of the symptoms that our children present with or come and verbalize. Childhood onset schizophrenia is a severe form of psychotic disorder. So we look at it as at 12 years or younger, but most of the time we look at even for early onset, when someone is below 18, it's still an early onset. Then we have now more of the childhood onset, where we see a 12-year-old or a 13-year-old or younger. Unfortunately, it's often chronic, often debilitating, and it has worse outcomes than patients who have later onset of symptoms. So that's why we also have to be very careful when we, when we're making this diagnosis, because it also sets a very negative sometimes trajectory for either the parent or the child when they know what's coming towards them. So we always ask early onset schizophrenia, very early onset schizophrenia versus adult onset schizophrenia. Is it the same? Is it different? So recently they're looking at why do we have to have the distinction? And they're looking at, as I said, very early onset is under the age of 13. So they will look at it that from around 14 and a half years is when are moving forwards towards older age is where you have now a slightly better prognosis. And it will present with also more of positive symptoms, which I would hope that they would come with a slightly better prognosis compared to the negative symptoms. So the younger the age, you will find many, especially if it's insidious in onset, we're looking at it as more of a virulent form of just the regular adult onset schizophrenia that we usually see. The pattern, the childhood onset, when we have an adult who we say has a poor prognosis or a poor outcome, the childhood onset schizophrenia mimics that most of the time. Yeah, because of course, if it starts early, that means you have a much, much longer course or duration of illness, unlike someone who got it much later. There's a lot of interruptions in many things. And unfortunately, also the psychosis that we find for childhood onset schizophrenia is usually more severe sometimes. And it can be very pervasive, very enduring, and it may be consistent. While some adults, you'll find they have periods where at least they're not psychotic, or they have periods where they have no symptoms. For children and adolescents who have schizophrenia, it's most of the time you stop medication immediately, you get a relapse. For an adult, sometimes you might find a bit of a time lag. But for schizophrenia that's occurring in children, then it can be non-episodic and it's unremitting. And as I mentioned, we think it's a more virulent version of the same disorder that we exhibit now in adolescents and adults. So just to look at clinical features, the DSM-5 diagnostic criteria remains the same for childhood and for adulthood schizophrenia. The symptoms or the diagnostic criteria does not change. However, for childhood, the symptoms, the child might be harder to diagnose. Why we say that is because there are some symptoms that we find in other childhood disorders, many childhood disorders, like, disorganized speech, disorganized behavior, in something like autism spectrum disorder. If a young child is not able to describe the delusions, and it could just be obsessive compulsive disorder, intrusive thoughts, but this person, we're just seeing them manifest with a compulsion. Sometimes we'll take it as bizarre behavior because they're not able to articulate. Yeah. So because of the symptom overlap, sometimes it's harder to diagnose childhood onset schizophrenia or psychosis in children and adolescents. Hyperactivity, restlessness, impulsivity that you'll see in ADHD may also be a bit difficult to tease, especially if children have different personalities. So if you have maybe a socially awkward child and also hyperactive, someone might sometimes mistake that for disorganized behavior, especially those who are extremely impulsive. So rule of thumb is you're always considering a differential diagnosis when you're working with a child during evaluation. So always consider, you have to be think even as you're taking your history, you're trying to tease out, could it be this? Maybe it's not this. And I think we're always hoping that it's not schizophrenia sometimes, because as I've mentioned, it doesn't have one of the best causes longer term. So there's not just it's just to highlight the DSM-5 criteria, just as a reminder. For schizophrenia in general, you have to have at least 2 of the following delusions. These are fixed false beliefs that are not shakeable. Person believes that they're very real. Could be anything. You're being followed, you're being poisoned, or even bizarre, that your body has been taken over by an alien. Yeah. hallucinations. These are perceptual disturbances. In schizophrenia, we have most commonly auditory, but young people will have even visual hallucinations, quite common. Some have tactile hallucinations, but the most common ones are the visual and auditory. You can have disorganized speech. You can have very grossly disorganized behavior or catatonic behavior. And we always forget about negative symptoms. We are very quick to ask about hallucinations, delusions, and bizarre behavior. But then we always forget that there's that child who has been isolating, has not been looking after their hygiene the way they should be. Their school performance has been dropping. They've lost interest in things that they're just existing. But especially in childhood onset, with the insidious cause or insidious onset that they get, some of them start off with negative symptoms, and you will see them when now positive symptoms have come up. Same thing we still observe even in adults, but many parents may just think maybe their child is just going through a phase. But we always have to think about negative symptoms. That's why we always ask about academic achievement, social, how the child is socializing, and also always ask about their hygiene. Not forgetting impairment of functioning. So that's usually our cause to treat. Otherwise, someone just comes with hallucinations only, and they're functioning very well, then we have to look on to other things that might be bringing this up. Caution: if a child is in the autism spectrum, does not mean that they cannot get schizophrenia. However, we diagnose it if we have very prominent hallucinations or delusions, in addition to the other symptoms that we talked about. Because a child in the spectrum already can manifest some bizarreness in behavior, might be aloof. So if you already have one who's in the spectrum, then you have to really be careful as you're teasing out the symptoms. You have to assess for cognition, depressive symptoms, and manic symptoms as you're ruling out, would it be, a manic episode or depressive symptoms? Just to also rule out, just as you're making up your differential diagnosis. Schizophrenia in itself is chronic, even in adults. While in depression, we will look at, cause specifiers when you're talking about remission, symptoms free for just a few months. For schizophrenia, we're thinking of a period of 1 year. That's the time we start thinking remission. Yeah, symptoms take time to go. So, or they can be maybe partly treated. So we have to make sure that the symptoms are actually good. You're treating adequately before you say that the person has fully remitted or is partial remission. So for these ones, we observe even longer to say if the person is symptom-free, at least for a year, when we're talking about remission in psychotic disorders. Looking at etiology or risk factors, no single etiology has been identified when we're talking about schizophrenia. We look at both a genetic and environmental contribution to causation. We do know that if you have a family member who has schizophrenia, there's higher risk of developing schizophrenia as well. But if you think about it, twins should have almost identical genetic material, but they don't always both have schizophrenia. So there's more to it than just genetic transmission, but that also puts you at risk. So looking at the various etiological factors, I start with genetic risk. First-degree relatives of patients who have an early onset schizophrenia especially will have a 5 to 20% higher risk of developing schizophrenia compared to the general population. Twins, almost a higher risk, which is about 50, it was about 50%, 49 to 45 to 50%. So that pushes the genetic agenda. We have these disorders, cluster A, personality disorders, together with schizophrenia and schizoaffective disorders. So we look at the familial schizophrenia spectrum disorders. Remember, even in adults, when someone has a schizotypal or schizopersonality, they're at higher risk, or they're higher risk of developing schizophrenia. So you have familial schizophrenia spectrum disorders where now a family member would be at higher risk of developing schizophrenia. So it is related. Or healthy relatives of patients with schizophrenia may have some subtle cognitive deficit, even if they're healthy and they don't have any psychotic symptoms. So you might find they may have troubles with cognition, some subtle abnormalities in attention, executive functioning, their working memory may be a bit off, or even verbal memory. So you might see that in healthy relatives of patients with schizophrenia, and they're not exhibiting symptoms. So it just raises, it puts them at risk also, that they're also showing such symptoms. Yeah? When we look at genetic risk, it's not as straightforward. We've been looking for genes related to schizophrenia for years and years and years. Hopefully we'll get somewhere. We're talking about a heterogeneous phenotype, because there, even where we expect identical genetic material, we'll still find people having some challenges. So there are various models or disease formulations that are theorized around genetic inheritance. So you can have where you have a common disease, but common disease, common allele model, where you have the penetrance is low, but this is very common in terms of presence of the genetic material. Or you can have a common disease, but the penetrance is very high. Yeah. So, but we are still even now figuring it out. We're talking about chromosomal abnormalities and deletions. We're trying to find out, is there a consistency? Do we have certain genetic markers? There are that have been identified, but they're not definite. Yeah? And if you think, going still in line with even with pediatrics and medicine, some of the early onset cases that we see have a more salient genetic cause. For example, earlier onset breast cancer. Most probably you'll have a family history of breast cancer in the family. Early onset Alzheimer's, for example, most probably you'll have a genetic link to that compared to where a person gets Alzheimer's much later in life. So even in pediatrics and medicine, so why not maybe psychiatry? So when we look at childhood onset schizophrenia, higher risk of genetic passage, or higher risk that there's someone in the family who will have schizophrenia itself. So especially if it comes in early. I'm sure you, especially when we used to maybe rotate in Mathare Hospital, you'd unfortunately find a mother who has schizophrenia coming along with her daughter who has schizophrenia. So one of those where you just see an obvious genetic linkage. But again, why we have the environmental part is because it's not exclusive. We can't say it's dominant or recessive, but we do find some commonalities. Looking at neurodevelopmental and anatomical abnormalities, so most of the times, looking at adults, we mostly have reduced intracranial volume and longitude over time. What? Okay. Over time, you'll find that there's a decrease in total cerebral volume. So they followed up individuals who have schizophrenia, so it's not static, and the volume goes decreasing over time, and also resultant ventricular enlargement. Brain growth is actually postulated to have started stunting even before the onset of the illness. So it's not that it's directly linked, as it's not that we start having some atrophy or shrinkage in brain matter and that's immediately. So they always see, like, in some of the individuals who have schizophrenia, the brain development started stunting way before they even started getting the symptoms themselves. Childhood onset schizophrenia, you'll find the initial volume, maybe for an initial brain scan, the initial volume is small already, smaller than general population. Then with follow-up of scans, they do find that there's a progressive decline in volume. And of course, there's larger ventricular volume as a result, with progressive increase in ventricular size, even as they continue to grow older. So that means then they are losing around a bit of brain cells and connections as well. But the question always comes up, how are these changes meaningfully related to clinical features? It's still under investigations. They look at small, like, even with executive functioning, frontal lobe, corpus callosum connectivity. So we are not sure, or we're still not sure 100% how all of these features that we observe in those who have schizophrenia are directly related to the symptoms that they present with. Yeah. We do know also there are those who have schizophrenia, but there are no changes in their brain matter volume. Yeah. So there's still a lot we don't know. There are different genetic transmissions that one might be related to less, to reduced intracranial volume over time versus others who are not. Are they, more virulent or more severe presentations that have more reduced brain volume? We're still not sure. fMRIs give a bit of a guideline in terms of white matter connectivity. They find, with investigations, you find that the abnormalities in the connectivity or the areas that light up. Early childhood trauma, or especially sequential, has been related with onset of schizophrenia as an environmental cause. Infections, especially links between viral CNS infections and later psychosis, have been linked to schizophrenia. Immunology, currently autoimmune or autoimmune presentation, or the role of or immune modulation in schizophrenia is actually a large investigative field. Just the same way genetics is huge in schizophrenia right now, even looking for links in immunology. There are those clients who present as a first episode of, say, lupus before the renal impairment with psychosis. And sometimes it's a very difficult psychosis to treat. Yeah, we've had a child I've looked after with one of our colleagues. Well, he got psychotic symptoms, very severe psychotic symptoms, and it ended up only clozapine was working, very severe, before the age of 18. Shortly after things have settled, then he has a diagnosis of lupus. So there's an autoimmune component of schizophrenia that we're still not yet grasping, and it's very linked. Same thing with encephalitis, and especially autoimmune encephalitis and presenting as florid psychosis, that if you're not investigating, you might not be able to pick. So those are areas that are really ripe for research right now. We know the role of dopamine and schizophrenia, so I'm not going into many details, so go look at it. Cannabis poses a risk, especially in vulnerable individuals. Not everyone who smokes cannabis gets psychosis. However, some have their symptoms of schizophrenia do tend to start manifesting around the time they start using cannabis. So there's a linkage there. Looking at epidemiology, we don't have a lot of data, even in the West, that regards pre-adolescent prevalence of schizophrenia. So some places will have, like in the US, they postulate about less than 1 case per 10,000. However, the numbers start increasing significantly during late adolescent and early adulthood. Then now it tips over to the 1% that most of us usually know, or for later onset. Male to female ratio, more males than females. However, this is also usually challenged. Is it masking of some symptoms? Is it overlap of symptoms? Are these the real? So there's always queries about the male to female ratio of schizophrenia. I think also because maybe males get more of, sometimes more impaired, maybe. That's why we do pick on that. But it's still, many people argue about whether this ratio is fact or not. I put prognosis earlier, not later, because sometimes it also gives us an idea on how aggressive we need to treat, and also how aggressively we need to support our children and adolescents who have schizophrenia. Prognosis is not the best for childhood and adolescent onset schizophrenia. They have a much poorer prognosis. Also because they've had a longer course to have the illness, so they over the years have greater challenges than those who get schizophrenia at a much later age. So over time, fewer close relationships, both because of the symptoms that they manifest, the isolation, the negative symptoms particularly, or because of the illness and maybe not being able to be as independent. So they form fewer close relationships. Less likely to be married. If you think about it, someone who has a long enduring course of schizophrenia, mostly you're also a little bit more isolated, even from childhood. So forming long-term relationship, even marital relationship or dating profile, usually they are on the lower side. Less academic achievement. Children with schizophrenia, because of the cause of illness or the severity, they might end up being pulled out of school every so often. I have a young girl I'm looking after, has been showing up to school, but hasn't learned for about 1 year. They weren't being able to figure out what was going on. So she's finally out of school. Hopefully getting better and resuming. And we always hope that we keep relapses at bay. However, unfortunately, they do happen. And especially they're transitioning from one level of education to another. You might find, especially moments of stresses, they might trigger relapse. More unemployment. Yeah, so this person is more disadvantaged and less capacity for independent living, especially if you're talking about response, partial treatment or incomplete or a partial response to treatment. So there's always something that might be, you might always have to have someone to look after you. And especially for those where symptoms are not resolving completely. You have to have someone to look after you, someone to remind you to take your pills, go to clinic. When insight drops, we have a relapse, and then, so most of the time, they have to live with someone. I think I've mentioned this a lot. Onset before adolescence, as well as an insidious onset. A more acute onset, especially with positive symptoms, a slightly better prognosis. However, it's still an early onset. But those who have had an insidious onset of development of symptoms appear to have a worse response to medication as well, This is where we find ourselves adding on top of each other, trying one medication and another, and sometimes going to that line. Higher risk of death by suicide. Violence is a potential problem, especially some we have delusions that push them towards violence. And this is in itself stigmatizing, puts the person at risk for various things and their danger to themselves and others. Severe impairment in social skills, limitations in academic and occupational achievement. You'll even find someone who was brilliant in primary school, high school, getting schizophrenia, and they start having limitations. Concentration is not as good as it used to be. They're struggling with hallucinations. So even sometimes finishing a university course becomes more tedious for them. Yeah. The longer a psychosis remains untreated, especially where there was an initial severe presentation, the harder it is to treat. So early treatment is key so that we have a slightly better prognosis. So identifying symptoms earlier and starting treatment as soon as possible. Unfortunately, also, sometimes on our side, it takes time to convince parents that they will need treatment and they'll need to follow up or monitor treatment for these children. And so you have a longer duration of untreated psychosis. If you have longer duration of negative symptoms, which sometimes people will not pick, but you realize later, maybe when they're not responding as well to treatment. So you also count the negative symptoms or count also the prodrome in terms of duration of untreated psychosis, if you can be able to identify that. But earlier treatment key so that we have a better prognosis. Things worth a mention during assessments. You have to have good engagement with the patient, with the family, empathy, and be very patient. This is a child who has psychotic symptoms, whether schizophrenia or not. Very scary to the parents, even when the child is not paranoid or the symptom, the bizarre behavior is very scary. So you also have to manage the parents, the family. You have to be empathetic. No quarreling, how come you took so long? They didn't know, but you have to be very patient. You have to take a very detailed history, especially developmental history. When you're taking history, remember I mentioned you're teasing out your differential diagnosis. So detailed developmental history, is it an autism spectrum that this child is much older and now his stereotypic behavior or aloofness starts giving the impression that it is, schizophrenia. Get history, if possible, from multiple informants, including family and school. Yeah? Negative symptoms, you always have to ask about them. You have to screen for comorbidity. They mask your symptoms, they complicate your diagnosis. You have to treat them so that your patient also gets better faster. Risk assessment, danger to themselves, danger to others, even where they're living. Will they be looked after when you start medication or treatment? Will there be follow-up? So those are things you look at. Physical examination, medical examination, as you're coming up with your differential diagnosis. You can use rating scales. KiddySADS has a good semi-structured interview on various disorders, including psychotic disorders and schizophrenia. When you're assessing, you're coming up with differential diagnosis. So many, we already alluded to, there are many causes of apparent psychotic symptoms in children. Yeah? And even when you're going now towards adolescents, some of our clients have borderline personality traits. Some symptoms in adolescents are reported rather than observed. Younger children, parent will be observing this child and seeing just a lot of bizarre behavior. we're looking at a new age of adolescents who come and report symptoms. Some even come as if they're checking them off a list. So we have to be very careful of our differential diagnosis. Is it a somatization? Malingering as well. I'm finding that we're starting to treat symptoms rather than coming up with a nice formulation to understand why this person has gotten unwell at certain times. We've had a look after one of my clients with one of the psychologists. Her psychotic symptoms would only manifest in a certain area of the school. So it is definitely not schizophrenia, but she also had other stressors that she was encountering. Yeah. So we have to be very careful on how we understand the psychopathology that the children present with. Now, one of the cases or studies that actually demonstrate the usefulness of a differential diagnosis is a childhood onset schizophrenia study, a follow-up study that's been going on since the 90s, where the inclusion criteria was onset of psychosis before the age of 13. You have to have a premorbid IQ of 70 and above, and you should not have a severe neurological disorder. So over the last 24 years, they've been reviewing various cases. About more than 2,000 cases have been reviewed in this study. 80% dropped off because at the end of the day, they ended up not even meeting the criteria for childhood onset schizophrenia. So about the 400 of those screened in person, 60% received another diagnosis, such as an affective disorder, severe anxiety, behavioral disorder. You have to remember that sometimes anxious individuals may dissociate. Yeah? So even anxiety is a differential diagnosis. So those ended up being dropped off the study. And those who appeared to likely meet the criteria of childhood onset schizophrenia were admitted into a research unit, underwent a complete medical washout, followed by a 1 to 3 week drug-free inpatient observation. So again, another 40% ended up not meeting the diagnostic criteria of childhood onset schizophrenia. At the most, a mood disorder diagnosis was made. Remember, they can also present with some psychotic symptoms. These ones were also followed up, so just to make sure that it wasn't an episodic psychosis. A 4 to 6 year follow-up study of the 33 who were ruled to actually have, childhood onset schizophrenia. The ones who had, they confirmed, the ones who were followed up after and they did not have schizophrenia ended up actually not having schizophrenia even after being followed for that long. So we have to be careful on how we conclude psychotic symptoms. Most commonly, we are swayed by hallucinations and delusions most of the time. Of course, we have to bear in mind that there's some bizarre behavior. So high rates of misdiagnosis remain due to symptom overlap, particularly for mood disorders. If you're not careful, someone who has a bipolar mood disorder will also have sometimes hallucinations or may have some, isolation or other symptoms might come in. Children do present with transient hallucinations and, some beliefs, or they sometimes exaggerate when they're telling a story or how they narrate things. So you have to be very careful on how you pick it as a symptom. Yeah. However, as much as I'm saying that you have to really think of a differential diagnosis always, sometimes psychotic symptoms in children and adolescents, even if you find that they were not childhood onset schizophrenia, they can be predictive of a psychopathology later in life. So we always wonder, is it a continuous phenotype rather than an all-on-one presentation. There's still a lot we don't know about schizophrenia, even in adulthood. So some of the things they'll talk about is normal fantasy, imaginary friends, transient hallucinations, especially while under stress. You have to rule out organic conditions, especially psychosis secondary to a medical condition. Yeah. And psychiatric condition ones I mentioned is autism spectrum disorder, obsessive compulsive disorder. Children may not be able to describe the thoughts as intrusive. So they might just come and start saying something is happening or something is happening, and it might be taken as a delusion. But you look also at the child in entirety. Are there other accompanying, maybe other symptoms, disorganized behavior? Are there hallucinations? Are there other things? Is there how much impairment of function is? So obsessive compulsive disorder, unfortunately, a lot of it is treated as a psychotic disorder. And you treat the things that you think are delusions are not going away. Some may describe the intrusive thoughts as voices because they're not able to articulate them, especially children. But most of the time they'll have distress from these thoughts or these ideas that keep coming, which someone will assume that they're hearing a voice. So obsessive compulsive disorder should be on high alert for it. Bipolar mood disorder, dissociative disorders can also mimic psychotic disorder. Severe panic attacks, some people do have transient hallucinations as well. I thought I'd increase, maybe just maybe like food for thought. Sometimes we have diagnostic dilemmas, or some cases seem straightforward, but if you keep following up the patient, you see them morphing in front of your eyes every time they present. So case one, actually a young boy I've seen very recently. I first saw him at the age of 13. He was in class 7. Presented with what seemed like a classic manic episode. Was trying to teach, thought that he could teach better than the teacher. He was not sleeping. He would hear voices. God was talking to him. He was talking a lot, and he was very hyperactive. So of course, we think bipolar mood disorder. Treated, went off medication, even did Form 4. So next time I'm seeing him is this year, but a very different presentation. People want to kill him. He's running away, he's hiding, he's stripping naked. Very bizarre behavior. He was hearing voices talking to him. He was very paranoid. This time there's no pressured speech. There's very different trajectory. So that's a time we always wonder about the diagnosis sometimes we make. Is there a continuum between some, especially mood disorders which would present with psychotic symptoms and schizophrenia? So it's just food for thought that patients can change in terms of clinical presentation. And these are young men, first time 13 years. The next time is just turned 18. So we can't say so we always wonder, is it changing? Is it just symptom manifestation or not? Delusions are never always the same for every patient. This other young man, we are looking at, is it psychosis or is it an obsessive compulsive disorder? First seen age of 13. However, the complexity is that, so a background, refusing to attend school for a long time, not following rules in school, last year started tearing up his brother's books that they will be bombed if they go to a certain school. Yeah, he had a long history of school refusal. But so there is some oddities in behavior, some things that he believes that he can't articulate or prove. So he just knows there's a bomb that's going to happen in a school. So there was a background of oppositional defiance disorder, and this time comes in as if he has a psychotic problem. And this had gone on for about maybe 3-4 months. But when he comes in for observation, there is no bizarreness in behavior. However, he appeared to be in the autism spectrum. So the question comes in, is this an intrusive thought that this young man who appears to be in the spectrum cannot be able to articulate, that it's giving him that distress? The tearing of books, was that a symptom of distress at the time? And that's how it's an intrusive thought, and it gives him distress. And because he's not as articulate, he will tear books so that others don't do something. The other question that comes in, is it just the peculiarities of an individual who is in the spectrum? So it's not as straightforward most of the time. So antipsychotics did not do any dent in his thoughts. He was organized, he was kempt, he did not have any other disorganized behavior. All those things that he used to do at home, well, in the hospital, no one has observed anything like that. So moving towards the obsessive compulsive disorder, not as straightforward to pick whether these thoughts are distressing or not, because he's not as articulate, has very black and white thinking. So that's another challenge we do have. This other young man, first seen at the age of 14, a brilliant boy, called to a national school, unfortunately got his first episode of psychosis around that time. He had low mood, he wanted to kill himself, but he would also hear voices. While he was in the hospital, he would even look for ropes so that he kills himself. At that time, a diagnosis of schizoaffective disorder was made. Fast forward now, and he'd been on treatment, managed to finish high school, but of course, remember what I said, struggles, interruptions of school, social isolation. So he's nowadays sometimes very self-conscious. When he's gaining insight, he'll ask also very many questions about schizophrenia that you almost feel this is pushing him towards a depressive episode. However, the diagnosis as he became an adult moved from a schizoaffective picture because of the floridly psychotic paranoia he just had. There were no, he didn't have, very low mood, did not have elation, but just believed some members of his family were out to get him. So we do have diagnoses now again changing to a schizophrenia. One of my lecturers used to say he really doesn't believe as such that there's anything like schizoaffective disorder. It is just schizophrenia. Such patients make me also agree with him, but don't take my word for it. So this is just food for thought in that how much we don't really know about schizophrenia. Our patients change in presentation, even as they're young, and then you see them in childhood onset, a very different presentation when they start transitioning into adulthood. Is it the same condition? Is it now a different condition? If we're to ever investigate this person in terms of genetics, would it be the same genetic manifestations? Do they have various conditions happening? Yeah. So we always have questions. Hopefully one day we'll really understand schizophrenia. Let's go to management. Let's say patients don't read books. They present in very different ways, a wide range and variety of presentation, and a very broad differential diagnosis. Symptoms may range, sometimes even in the same patient in different times of presentation, from mild paranoid ideas to very fixed delusions with hallucinations that even urge a patient to violence. I had a girl the other day who just pulled out her nail from a command hallucination. They can be very severe. So we have to consider also risk to themselves as we are planning management. Self-harm, suicide, risk of violence, nature of risk and associations with the current symptoms that they're having. Degree of insight and the likelihood that this person will cooperate with medical management. We have to think, do we admit into a psychiatric facility or not? What are the social circumstances? There are very many factors that come into play that now start guiding us on how to proceed. Yeah, we don't admit all patients who present with schizophrenia, even if they're children, but we are guided by how they present or how their symptoms manifest. To admit or not to admit. Those who need hospital admission, high risk of suicidal acts or homicides, even very young children with schizophrenia can get very aggressive and violent. Yeah. Other illness-related behavior that endangers relationships and reputations. So if they are very disinhibited, they strip naked, we may end up having to hospitalize them. Very severe depressive, psychotic, depressive or catatonic symptoms. So schizophrenia can come with catatonia. Autism can also come with catatonia. So again, we throw another spanner in the works. Lack of capacity to cooperate with treatment. So we've had a girl recently, the parents finally had to bring the child for admission. Bizarre behavior, psychotic behavior, we come up with a plan of treatment, do all the investigation. So this girl is about, 16? Has quite some significant brain atrophy, but is in high school, so she may have a very mild intellectual disability. Parents decide, let's take the child back to school with her medication, they'll give it there. The school calls them back with the same pack of medication a week later. This girl never even took one pill. They went home with the girl, hoping that she'll take medication. She never took it. So we've had to admit. So capacity to cooperate with treatment. So even young children sometimes will refuse medication. Insight disappears whether it's a child or an adult. Where outpatient treatment fails, we may have to hospitalize. Non-compliance with treatment plan. This can come from even the child or even the adult who's looking after this child. Sometimes where there's lack of or loss of appropriate psychosocial support. Maybe this particular child was being looked after by a parent, and was already psychosis. So we may have to admit to stabilize the child. When sometimes we want to change medication, we cautiously can admit for that, because sometimes, depending on how the relapses have been, risk of violence, we would want to evaluate that in a control center, and also to address comorbidities. So that's where we admit children, adolescents, and I think the same guideline works even for adults. Workup as part of assessment of a differential diagnosis. You have to be very vigilant for general medical conditions. So a lot of workup may be guided by how the patient presents. Yeah. Sometimes for you to higher index of suspicion for a general medical condition, even if it's psychosis, very atypical history, or a very acute or very, very early onset, a very young child who's about 4 or 5, presenting with hallucinations, they're seeing bugs, they're seeing things coming at them, it might be just be medical. Maybe a drug reaction. We used to see that when we used to use, it's called Caletra. What was that? There was a HIV drug that we used to use some time back. I don't know if they still use it. We used to see a lot of hallucinations and psychotic behavior in children around when they're initiating the treatment. Onset triggered by surgery or a viral infection. There's one time we had admitted a young boy came all the way from the coast but just before, even if they'd had psychotic symptoms or bizarre behavior for about 10 days, just before that, they'd been treated for a febrile illness that was very non-specific. So you had to get in a neurologist to come and see. It ended up being an encephalitis, and they were transferred out to a medical facility. Medication, I've already alluded to some medications can trigger some side effects. Cognitive and developmental regression. You might have to think of something slightly different. Atypical symptoms, confusion, catatonia. Catatonia, many times we only think of psychiatric disorders, but you can have catatonia because of medical conditions. Co-occurring physical symptoms, such as seizures, when you have malarashes, most of the time it goes into, signifies many things, but also autoimmune conditions. Gastrointestinal symptoms, dysmorphic features, raises your index of suspicion that maybe it's not purely psychiatric. MRI or CT scanning does give an, exclude any other organic causes. EEG, very useful, especially when you have episodic symptoms. They come and then they disappear. Psychosis, then goes. So EEG is very warranted. ECG, especially before you start in your low potency antipsychotics like quetiapine, if we can. Many times we just do our baseline labs, but ideally, especially if it's schizophrenia, because the doses might end up being higher, it does affect your QT interval. It's good to think about it as a baseline. Biopsychosocial approach still applies. So still more on management guides. So we're looking already, are we doing an inpatient, outpatient, or daycare? That would also guide what we do with the patient. The medication, how they presented also, supportive psychoeducational and specific, individual work, social skills training. You can't forget family support, education, manage comorbidities, and ongoing risk assessment. Just because a person is in the ward doesn't mean you stop evaluating for risk. Very key, education or vocational input. Remember, our kids end up missing a lot of school, months, yeah? So many of them, we have to now come up with a plan to reintegrate back to school. Are we going to try a special education provision? As they're growing older, we may need to start thinking about supporting college or work placements, because now they've come from being very young children. Now they're going into individuals who are supposed to be looking after themselves. We have to be aware of consent, capacity, legal issues, what they can do. And then currently also access to benefits, their tax rebates that they can benefit from. I'm not sure if that's applicable to the parent who's looking after a child who has a severe mental disorder, but maybe that's something they should consider. Where they have cutoffs, children health, mental health services, adult mental health services. It's the same thing with HIV. Kids never wanted to move from those clinics to transition to adult clinics. So we have to see how they can transition. Medication doses. Now you're an adult, you should be able to look after yourself, manage your treatment. So these are things we think about as you're transitioning these children, or even managing on the long term. Parents will even come with hard questions from the word go. So this, I've read about schizophrenia, I'm seeing it's lifelong. What will happen if something happens to me? So parents already start worrying way in advance. You should also start seeing and be able to guide them where you can. Pharmacotherapy is the one illness where pharmacotherapy is mainstay. Neuroleptics are the standard. It's not a pharmacology lesson, so please go and polish up on your pharmacotherapy. The various types of neuroleptics, first generation, second generation, what's the difference? So part of it, vigilance of side effects, of adverse effects. Children and adolescents are more prone to extrapyramidal side effects. We also find especially young males are more prone to some extrapyramidal side effects more than the girls. So you have to be very vigilant of adverse effects, and those are the ones that will make your child drop out of care very quickly or scare the parents out of medication. Yeah. Monitor weight, blood pressure, glucose, lipid level, it's warranted. In adults, it's compulsory. In children and adolescents, not fixed, but I think it's something that would make sense. Most of the time, we'll start with second-generation antipsychotics. Of course, there are areas still in the country we don't have second-generation antipsychotics. Haloperidol still works. It's quite potent, and it's actually one of the ones approved for young people. Quetiapine, olanzapine, aripiprazole, lurasidone, haloperidol, risperidone, especially for teenagers. For very young kids, we start with risperidone, more studied. But that doesn't mean that, especially remember I've mentioned they're hard to treat. There are times you find yourself with polypharmacy, or drugs are just not working, or you're not getting full benefits. There are times we end up with clozapine in child and adolescent mental health. Yeah. And it seems to work, especially in those very severe cases that are just not responding to treatment. So that is something we think about. It's not the one we start with, but when we see they're not doing well, clozapine is also useful. But of course, clozapine comes with all this other monitoring that we need to do. So if you're going to jump into clozapine, please monitor your child for side effects. Psychosocial management, so it's not just medication. Social skills training. Yeah, sometimes our kids go off school for such a long time, reintegrating them back is hard. Yeah. Supportive environment, we really have to psychoeducate. This illness is also an expensive affair. Parents get frustrated, but they also need to see their children well. So sometimes we do have support groups for parents as well, just to help them cope. Structured individualized education programs moving forward. Hard to do sometimes. Kids end up falling back a grade, but in some schools, they do really come up with a tailored program. Or you have a child in a small school, they would be able to support them. They do have, supportive psychotherapy. It's more of also psychoeducation, especially if you're working with a young child, encouraging reality testing, helping the child identify these are symptoms, especially the ones who are not very debilitated, and that they should be able to articulate that they're about to have a relapse. Yeah. Cognitive behavioral therapy in terms of challenging thoughts that may come along with it. Low self-esteem can hit hard a child with childhood onset schizophrenia. Psychoeducational group interventions, where there's some which are available. Substance abuse treatment program for those with substance use problems. Even adolescents will still sometimes go with that trajectory. So we have to think about looking after the substance use problem as well. We're managing also comorbidities. Nutritional interventions. Many of the medications that we do use may come along with weight gain. So healthy diet, that needs to be really encouraged and taught. Where required, various consultations. So you can have speech and language therapy where necessary, occupational and physical therapy. Neurologists, if you're in a center where it's available and you have maybe a child with dysmorphic features, you can consult a genetist. And then regular monitoring visits so that lowers the risk of losing insight. Remember when even our adult patients miss one clinic, the next time you see that person, they relapsed a long time ago. They can't look after themselves. Regular monitoring visits, yeah. If you have a check-in system, the better. Yeah. as you are also encouraging this person as they're becoming an adolescent to be able to look after their medication. Prevention. There's always a debate. We treat before emergence of symptoms. We've talked about, people always ask, so I have a high risk of schizophrenia in my family. And people come very scared, by the way, especially if they've seen it happening. Usually a question, do we treat before emergence of symptoms where the index of suspicion is high? That's something that's debatable. Because, well, might end up taking medication for nothing. There's no genetic testing, so we can't be able to tell. And like, remember I'd mentioned genetic testing in young patients who get breast cancer, genetic transmission. So earlier onset illnesses like breast cancer in a younger person, most likely there's a familial transmission, or Alzheimer's, early onset, most probably there's a familial transition. Unfortunately, we don't have a certain genetic test that we can do for schizophrenia. So this may or may not be a moot point, but yeah, something to think about again. Yeah, I think I can answer questions. Thank you.
Thank you so much, Dr. Kamau. That was a lot of information.
Food for thought.
Very educational. Yeah, some take-home points I personally got were we term it very early onset if it's before 13 years, and that we should not ignore negative symptoms, and to keep in mind that early onset schizophrenia may begin insidiously with negative symptoms. You reminded us of etiology and risk factors, and to not forget that there are neuroanatomical abnormalities in the brains. When it came to prognosis, again, that the prognosis is poor if the onset is before adolescence. Before we continue to Q&A, maybe we'll allow Sun Pharma, who are our sponsors for this webinar, to just give us a brief talk about their products. Please go ahead, Sun Pharma.
Yes, thank you, Daktari. I will go on and share my screen. Please let me know if you can see it.
Yes, it's visible.
All right, thank you. Yes, so my name is Stephen Bethy. I work for Sun Pharma East Africa Limited. I'm an assistant product manager. I work in the marketing department for Kenya. I take care of several therapies, including psychiatry, neurology, gastroenterology, orthopedic, and a few others. So thank you, KPA, for giving us this opportunity to partner. And my presentation tonight will be brief. It's based on one of the treatment options that Daktari mentioned in the management of early onset of schizophrenia. And this is our brand of quetiapine. I will be specifically focusing on our slow release formulation, which is called quetiapine nasal. But just before that, I just want to give you a brief about Sun Pharma. As you know, we are the 4th largest global specialty generic company. We are actually a company that is well known. Our products are accepted globally because we always adhere to the highest quality standards. And as you can see, we are also present in the US generic market. As you know, the American market is very highly regulated, and you really have to meet the highest quality standards for you to be even allowed to market your products there. We are also the biggest pharma company in India. We have a whooping lion's share in terms of the sales in the Indian market. In a market where over 40,000 pharma companies are registered, Sun Pharma boasts 8% market share, which is very significant. And we are also present in the rest of the world. We have 43 manufacturing facilities spread across the world. We manufacture in the Americas, in Mexico, in New Jersey, in Massachusetts. We also manufacture in Canada, in Ontario. We manufacture in Russia. We manufacture in Malaysia, in Israel. In Africa, we manufacture locally in 3 countries: South Africa, Egypt, and Nigeria. And we also manufacture, of course, in India, where most of our hubs are. Most importantly is that our manufacturing facilities are actually approved by the global regulatory bodies, including the FDA, the MHRA of the UK, and also other local regulators like our PPB in Kenya. So whenever you prescribe our products, you can rest easy knowing that your patients are getting the absolute best products that they can be able to get. And the advantage of generic, especially generic companies and generic products that come from reputable companies, is the fact that you're able to get the best quality and also at a very affordable price. Because previously doctors were torn between the dichotomy of quality vis-a-vis affordability. But with companies like Sun Pharma, who have been in Kenya for the last 30 years, you can be sure that you can be able to get the best of both worlds. Your patients will be able to get the best quality, and they'll also get it at a very affordable price. So in Kenya, we've been here for 3 decades. We've been consistent in this market. We're actually one of the best performing companies in the Kenyan market. We're actually in the top 10 of the biggest companies in Kenya. And we can assure you that we'll be here to stay, to continue treating our patients with the best products. So quickly jumping into my product presentation, I know you are familiar with Quitipin. This is actually the biggest quetiapine brand in the Kenyan market. And this is a product that Sun Pharma has really done well in terms of the psychiatry segment. And the versatility that comes with the quetiapine in being able to be used in low doses as a hypnotic, in mid doses as an antidepressant, and in high doses as an antipsychotic has really helped us to reach many patients. And given that you doctors have prescribed this brand and you trust it, it is upon this platform that then we delve into the next level by launching a product that is the same molecule, same brand, except the addition of SR, which actually means slow release. So Quitipin SR is a product that has been in the Kenyan market now for 1 year. And in that 1 year, we've seen some good response in the market, but we are still a long way in terms of where we want to get with this product. Hence, the need for this meeting, because we want to elucidate on some of the reasons why this should be your go-to in terms of management of your patients with schizophrenia, bipolar mood disorder, and other indications that you use quetiapine for. So we do know that there are a lot of unmet needs in the market in terms of treatment challenges. And we know that efficacy sometimes is difficult to achieve in patients, and especially when the patients are unable to tolerate the product, they are getting adverse events, or when the patients are not able to comply. So compliance and tolerability are very key challenges to efficacy. Comorbidities complicate the already precarious situation, and sometimes these patients end up even having even poorer outcomes. So as I mentioned, one of the most important factors in determining quality clinical outcomes is whether the patients are able to tolerate the product, because we do know that when patients experience adverse events, sometimes they might end up dropping the treatment regimen, which is detrimental to the treatment. But one of the most important factors to good clinical outcomes is actually compliance. And this is actually the Achilles heel of patient management. And the most frustrating thing is that the doctor barely has anything to do with it. And very often there is very little you can do when the patient is not complying. But thanks to Sun Pharma and the product I'm going to talk about, I'm going to show you something you can actually do about that situation. We do know that side effects, like I said, affect compliance. And we do know that when patients are able to adhere to the treatment, then of course the clinical outcomes are better. There's better symptom control, there's reduced risk of relapse, and also reduced rehospitalization. But we do know that one of the most significant impediments to compliance is actually polypharmacy. When patients are taking more than one tablet of that drug, or more than one, they're taking the drug more than once in one day, then that becomes a problem, because patients always love their convenience, and anything that is impeding their convenience then becomes something they're not likely to adhere to. So we do know that poor adherence is also a very key driver of poor clinical outcomes. And we do know that patient outcome is basically directly proportional to compliance, and the compliance is directly proportional to the ease of the dosing regimen. So this slide actually talks about some of the factors positively and negatively impacting adherence. And on the positive side, I want you to pay attention to the red triangle, and it talks about once a day dosing being a very key driver of patient compliance. So this means that patients who take the product once, especially at night or in the morning, are more likely to continue the treatment. Because think about a patient who works in a high activity industry like the transport sector or the construction sector. These are not patients who are likely to take time off to go and take their lunchtime dose. Sometimes they come home very tired and might even forget the other dose. So if you're able to give them something that they can take once a day, then that works well for everyone. In terms of negative factors, look at the side effects. These are some of the things that affect compliance, especially when there's things that are going to affect how the patient will look, like the weight gain, things that affect concentration, like sedation, and others. So these are able to impact on the patient adherence. But worry not, because Sun Pharma is here to provide you with a solution. And this solution comes in the shape and form of Kutipin SR, because Kutipin SR is going to give you the dual benefits that are going to help you to combat the two most important impediments to good treatment outcomes, these being compliance as well as adherence. So when you look at the Kutipin SR pharmacology, Kutipin SR is represented by the orange line, and the immediate release formulation is demonstrated by the blue line. And you can see the peaks and troughs that are available or that are made possible in the immediate release formulation. Actually not the case for SR, because we have more consistent plasma levels, and we do know that the peaks and troughs in serum concentrations can be a catalyst for adverse events. And actually in Kutipin SR, only less than 5% of patients actually experienced side effects. Of course, the indications remain the same. Schizophrenia, BMD, but most importantly, there's one additional indication that is actually FDA approved, which is not approved for immediate release formulation, and this is management of major depressive disorder as an adjunct in patients who have either intolerant or unable to get a good results with the other antidepressants. In schizophrenia, we know that clinical trials have proven that the once daily administration actually has been able to allow us to have more rapid escalation, dose escalation. And this also gives you efficacy across a range of symptoms in the acute treatment of schizophrenia, as well as preventing relapse in patients with stable disease or with significantly longer times to relapse in such patients. In schizophrenia, it is actually been proven to be superior to olanzapine and haloperidol in management of schizophrenia, both positive and negative symptoms. And we do know that the versatility of quetiapine is an added advantage, and also it's very efficacious in the maintenance, of course, with lower incidence of side effects. In bipolar mood depression disorder, it also gives you superior efficacy with the convenience of once daily dosing, and also the efficacy and bioequivalence remains the same as the immediate release formulation. So your patients are not disadvantaged in the efficacy just because they're taking it once. So the dosing, like I mentioned, remains once daily. So what you do is that you convert the total daily dose of the patient and you give it at once. And this is demonstrated in the next slide. So if you have a patient who was taking 150 mg twice daily, then you're supposed to give them the 300 mg once daily. If you have a patient who was on a total daily dose of 600 mg, they were taking 300 mg twice daily, then what you do is that you can give them 300 mg quetiapine SR, but you give them both tablets at once, because the magic of slow release formulation is that you only need to give the total daily dose once. So as I finish, these are 5 good reasons to prescribe quetiapine SR. So number 1, it is bioequivalent to multiple daily doses of the immediate release formulation with less pill burden and better compliance. And who would say no to that? Secondly, it also is as efficacious as the IR formulation and also superior to, of course, placebo in tests done on schizophrenia and bipolar mood disorder. It has similar safety compared to IR, but it is more tolerable because of the consistent serum levels with the lesser incidence of adverse effects. And lastly, for patients whose cost is a problem, the once daily actually allows you to save money for the patient. And actually, some calculations we've done locally here actually reveal that for 1 year, the patient is likely to save between 10 and 20,000 shillings in savings because of conversion to once daily dosage. So as I finish, you know that Sun Pharma is your one-stop shop for all you need for antidepressants, antipsychotics, anxiolytics, and some of the famous products we have, of course, known to you, Nexito, Alzolam, Zosat for your patients with anxiety, patients with major depressive disorder, of course, Nexito, Meters, Zosat are also your go-to products. Patients with MDD, with somatic pain, we have your Dozella, which is our duloxetine. And of course, for the antipsychotics, we have quetiapine, immediate release formulation, quetiapine, slow release formulation, Oleance, which is our olanzapine, as well as Sizodon, which is our risperidone. So I will bring it back to Daktari, and thank you so much for giving us the time to talk about our products. Thank you.
Thank you so much, Steve and Sun Pharma, for that reminder on quetiapine SR. Due to time, let's move on quickly to the Q&A session. There are a couple of questions in the Q&A box. Maybe I'll begin with those ones. Mary Muigai is saying that was a beautiful presentation. I'm happy to have been here. Just wanted to know, do we consider ECT at any point in treatment? From Kirinyaga, thank you.
Yes, so for patients who are very refractory to treatment, we do consider ECT. Not usually the best, it's not usually the first ones we think about. So it's works quite well, we find, even for, especially for mood disorders. Sometimes for certain schizophrenia, depending on what you're targeting, it might not work as well. But it's worth a consideration, especially for patients who are not responding to treatment. And that we are thinking maybe on the adolescent age group or the later adolescents, not very young kids.
Okay, thank you for that. If you have any questions, please put them in the chat. Okay, Modani Mudiga is asking, may you suggest an approach that works for when psychoeducating parents, especially at the phase of ruling out differential diagnosis or when the diagnosis seems unclear?
Okay. I think most of the time you're walking with the parent on this journey. You're not even, at that time, you will tell them this is what it might be. You'll explain to them the symptoms or make them rationalize the symptom. Most of the time they will come, especially with bizarre behavior, or maybe the child is talking things that they're not understood, or lack of sleep. So it's not just one symptom that we're looking at. As you're doing investigation, or even when sometimes we are investigating as we give medication for acute presentation. So we have an agitated or aggressive patient. We will sometimes start treating as we are investigating because we will not have just the person just running around. So when you finally have a clear diagnosis, then you explain to the parent that this is what it is. This is what we'll have to do for it. This is how it might affect your child. We have medication, explain the side effects of the medication, because you'll be working with them as you're doing various tests. Every test you do, you have to explain to the parent. So if you're doing baseline labs, you just don't tell the person we need labs. We're doing this test to rule out any other issues that the child might have. If you're doing an MRI, you have to explain to the parent why you're doing the MRI so that they're always on track with you. Yeah. If a medication is not working, maybe you've tried medication, then explain to them, I expected at this dose, it will work and it hasn't worked. We may have to increase the dose, yeah? Or we'll be increasing the dose every so often as we review. There are times you actually tell the parents, we may have to now go back a little bit to the drawing board. We're expecting symptom improvement, but something is not working. So you can even investigate some more. I've had to do ANA and ENA tests sometimes just to rule out any rheumatological or connective tissue disorders. So you're allowed to investigate, but as long as you're working with the patient and explaining to them what you're doing, usually it's not about a technique, just being on the same page with them and being honest as well.
Okay, thank you for that answer. Ala Mawad asks, is there a role of injectable antipsychotics to manage schizophrenia in the pediatric group?
Okay, I've used in the adolescent group, age group a lot. Most of the younger population, we do work with oral medication. We use injections in acute phases. First of all, very young children and adolescents are quite prone to side effects. So you can turn to an injectable antipsychotic, especially if compliance is wanting. There's no supervision for medication, you can do that. I have some adolescents who are even on either fluansor or on flupentixol or even Inveda itself. But those ones, it's when you've seen they're not taking medication, they're in a space where maybe they're informed for they have to do exams, we cannot be risking relapses, and this person is not non-compliant. Insight goes out the window for adults and children similarly. Children, though, parents may emphasize you have to take medication. Adolescents gets a little bit more challenging sometimes. So we do use injectable antipsychotics. They say like paliperidone you can use in adolescents. Mostly the orals, I think they've been approved for that. The injectables depends on the country. Sometimes I find we do use them off-label sometimes here, so but they do work. But we have case by case. Yeah.
Okay. The next question is asking about the use of clozapine in management of children with schizophrenia.
Yes. So as I mentioned earlier during the presentations, we have had occasions where we've had to turn to clozapine, in adolescents especially. Symptoms are not remitting. It's some patients like you, there's nothing that's really working. You've maximized one drug, you've tried 3 different drugs. Some barely work. So we've turned, not many, by the way, children are on clozapine. But yes, you can turn to clozapine, but you have to monitor because clozapine does come with its hematological side effects, comes with weight gain, excessive drowsiness. So you really have to weigh whether you want to try clozapine. But many times, as a last resort, it does work. And you find it might be the only thing that's actually ends up working for that particular child.
Okay, thank you. Well noted. Maybe we'll take a couple more questions. So an anonymous attendee asks, how common is anti-NMDA autoimmune encephalitis in adolescents presenting with psychotic symptoms? Should we prefer MRI over CT scan to rule out organic causes?
Okay. I'll honestly say I'm not sure the prevalence of the encephalitis. First of all, it can be missed unless you're very vigilant. But mostly you'll find there was a previous maybe a viral infection, or there was sometimes of inflammation, a fever or something like that happened. It's very virulent. You'll try things, but then sometimes encephalitis occasionally does come with altered state of consciousness, unlike what you'd find in regular psychotic episodes, unless the person is going towards catatonia. I'm not sure about the prevalence, but many times we end up co-managing with neurologists. Yeah. The second question was, and I think that
the second question, you already answered it.
Oh, okay.
Yeah. So maybe our last question. Sorry.
Yeah, but I'm saying a lot of attention is shifting towards the immunological part. Looking for, making sure, because there are times we'll end up treating episodic psychosis, and it might just be an autoimmune process going on, which we've seen a lot, as I mentioned earlier, with lupus. So if you can do a full workout, that's fine. Oh yes, I remembered the second question. You asked about MRI or CT scan. MRI, good for soft tissue, so ideally MRI. If it's not available, some centers don't have MRI, or some areas don't even have MRI. A CT scan is okay. So MRI would be better. There are times when people do a CT scan, see suspicious lesions, and then start having to do an MRI again. So if you can start with an MRI, especially, but if there's a head injury, CT scan better.
Okay. So the last question of the evening is from Eunice Temet. Would you advise the adolescents to take courses like medicine and engineering once they have a diagnosis of schizophrenia and are controlled on meds?
Oh, I can't. I actually do have clients who are doctors and they have schizophrenia, well-managed, brilliant people. I will not, unless maybe they're really struggling. We encourage normalcy. Someone is brilliant and they're able to do the work, why not? So it doesn't mean that they can't. So in med school, we did have individuals who I think at the time we might not have been aware it was schizophrenia, but over time you get to know. But these are brilliant individuals. So if you start telling them you can do, and they're passionate and they're knowledgeable and they can do the work. And your question also added that this person is well managed on medication and they're compliant. I think they can. We are trying to bring down stigma. Yeah. Of course, different relapses. So you always have to have this person being monitored quite well so that the chances of losing insight are very low. Yeah. As much as I've said I had I've looked after colleagues who've had schizophrenia, I have one who is actually very vigilant about symptoms. Lack of sleep, they'll even, I don't want to get back there. I don't want to get back. I don't want to get back to where I was once. I can remember the hallucinations. I can remember 2 years of my life stopped. So some are very driven by what they've lost, that they're so consistent on treatment. There are some who have even side effects, and you suggest maybe we can't reduce those, not medics necessarily, but individuals who have schizophrenia, but they're very in tuned and they have a fear of relapse. So when they're very stable and maybe they're having some drowsiness and you suggest, okay, you've been on this, we can reduce your dose a bit as a maintenance. Some refuse. They don't want to risk a relapse, and that's where now full insight comes in. But the many clients, insight shifts. So missing follow-up, feeling like you're better, being in a stressful space and you're feeling, oh, I can't do it. Missing pills for 3-4 days and then said, okay, let me continue not having to take medication. Then that comes back.
Okay, thank you. I think, yeah, it's important to always remember having a mental illness doesn't stop you from achieving your goals and dreams, and it doesn't make you incapable of studying, especially if you're well controlled. So lastly, I don't know if this is a comment, maybe it's directed to Sun Pharma. Anonymous says, a very mindful presentation. Deepen SR has been a good medication and has been using it for a time. The only problem is in the management of bipolar mood disorder 1 and schizophrenia has shown weakness on the mood and sleep patterns. Is there a way we can up the sleep and mood stabilizer effects rather than adding a pill burden, e.g. switched from normal quetiapine 400 mg BD to quetiapine SR 400 mg on a long-standing 34-year-old schizophrenic patient? So I think the question is there a way we can up the sleep and mood stabilizer effects rather than adding a pill burden?
So I'm not sure if this question is coming from a client perspective or from a clinician perspective. But I think in the presentation by Sun Pharma, they did give guidelines on transition. So if this is from a patient perspective, I would advise they also have that conversation with their doctor. If there have been side effects that they can't tolerate and they want to switch, then they should talk to their doctor. If it's from us, I think the presenter from Sun Pharma did very well explain the switch is not that hard. It does reduce the pill burden. For some, sleep, the drowsiness is not as heavy. There's some patients who may have a bit of drowsiness when they start it off, but they some stabilize. So it's a good switch if you're reducing the pill burden. I don't know if I've answered, unless the rep from Sun Pharma has a different response to the question. Yeah.
Yes, Daktari, that is actually very well answered. I think the benefit that SR brings is the once daily from BD. So like you said, the discussion on what dosage works well for what indication is to be had with the doctor.
who is seeing the patient, but definitely the standing benefit remains once a day dosing, regardless of what dose you are giving, and also the tolerability that comes with the slow release formulation. Thank you.
Okay, thank you for that answer, Steve. I hope, Anonymous, that that question was well answered. Maybe Dr. Judy, you might have a closing remark.
Okay. Well, mine is just to say thank you for, it's always a pleasure to sometimes talk about things you're passionate about and share questions that you've asked yourself about. So I'm hoping this added to your fund of knowledge in the management of schizophrenia. I'm also hoping it's created a few more questions for you, because when you have questions, you learn more, you want to know more. For schizophrenia, psychotic symptoms, take-home message is be patient and take a very good history. Investigate your patient, and then early intervention is key. Early intervention, early intervention, early intervention. So yeah, that's mainly my take-home.
Okay, thank you for that. We could feel your passion throughout your presentation. It was really, it was really informative and detailed. You reminded us to do a thorough workup. You reminded us about pharmacotherapy and about psychosocial management as well. That we have to be keen on the social skills and remember the other social challenges that early onset schizophrenia comes with. And importantly enough, to think about prevention in case it runs in families. So thank you very much for that. I learned a lot. I'm sure everyone learned a lot. We look forward to another topic soon. Thank you, Sun Farmer, for that presentation on deepen. I hope it's stocked everywhere so that we can assist our patients. KPA wants us to remember that the next CME will be advertised as it draws closer. There being nothing else and it almost being 9 p.m., I think we can close today's CME and call it an evening. Thank you everyone for attending. Thank you for showing up. Let's do this again soon.
Thank you.
Okay. Good night.